Okay, guys, it is June 20th, 2022. Let's get back to it.
A 36-year-old woman comes to the office due to worsening shortness of breath. The patient has a long-standing history of nasal congestion and frontal headaches that partly improved after nasal polyp removal a year ago. Over the past several months, she has experienced increasingly frequent episodes of chest tightness and wheezing. The patient has noted that the symptoms worsen after she takes over-the-counter analgesics. She has no pets, and there have been no changes in her environment. She does not use tobacco or alcohol. Which of the following is the main driver of pathogenesis of this patient's symptoms?
So this is like ASA, like triad thingy. Oh, I forget what is the name of that triad? It's like nasal polyps, aspirin insensitivity, and asthma. But yeah, let's see. I don't know what mediates it. I wonder if it is autoantibodies, like preformed autoantibodies, that hypersensitivity almost. I'll just go with IgE. Okay. The exact disease is aspirin exacerbated respiratory disease. Okay, let's figure it out.
This patient's presentation is most consistent with aspirin-exacerbated respiratory disease, AIRD, a non-immunologic reaction to aspirin, and other non-steroidal anti-inflammatory drugs NSAIDs. AIRD should be suspected when the SAMTR triad is present. Asthma,
Samter
egg,
triad.
intermittent wheezing, chest tightness, chronic rhinosinusitis, egg, nasal congestion, frontal headaches with nasal polyps, NSAID-induced respiratory reactions, egg, worsening symptoms after over-the-counter analgesics, egg, ibuprofen, AIRD. Pathogenesis involves increased production of pro-inflammatory leukotrienes and decreased production of anti-inflammatory prostaglandins. NSAIDs inhibit the cyclooxygenase, arm of the arachidonic acid pathway, COX-1, COX-2, to block prostaglandin synthesis, shunting it toward the leukotriene production arm. AIRD symptoms are due to this leukotriene excess and mimic asthma or rhino. Some patients may exhibit more dramatic symptoms, including facial flushing, urticarial eruptions, angioedema, and anaphylactoid reactions. Egg, bronchospasm, hypotension, usually occurring 30 minutes to 3 hours after NSAID ingestion. Unlike anaphylactic reactions, these pseudoallergic reactions are not Ig-mediated. Treatment includes avoidance of NSAIDs. If NSAIDs are absolutely required, desensitization is sometimes necessary. Leukotriene pathway inhibitors, egg, Solutin, montelukast can also improve respiratory and nasal symptoms. Aspirin-exacerbated respiratory disease is a non-immunologic reaction that occurs when cyclooxygenase inhibitors, egg, aspirin, other non-steroidal anti-inflammatory drugs NSAIDs promote the imbalanced production of leukotrienes over prostaglandins. The classic triad includes asthma, chronic rhinosinusitis with nasal polyposis, and NSAID sensitivity. A 23-year-old prima gravida at 29 weeks gestation comes to the emergency department with sudden onset severe shortness of breath. She woke up today with a fluttering sensation in her chest, which progressed to significant dyspnea, dry cough, and an inability to lie flat. Recently, the patient has had some exercise intolerance and tiredness, which she attributes to pregnancy. Her medical history is significant for recurrent sore throat requiring tonsillectomy as a child. She is a lifetime non-smoker and does not use alcohol. The patient's lifestyle is mostly sedentary. She immigrated to the United States from India 5 years ago. Her blood pressure is 110/60 mmHg and pulse is 144/min. The patient appears uncomfortable. An ECG shows atrial fibrillation with rapid ventricular response. Which of the following is the most likely diagnosis?
So what's the diagnosis? Honestly, I'm not sure. Like, she's an immigrant, so there's like, plus the whole sore throat as a child, that kind of gives me like the mitral stenosis vibes because of rheumatic fever. We've got where is it? The inability to lie flat, giving me like aortic insufficiency vibes. like the 144 heart rate, maybe like a hypertrophic cardiomyopathy. Hokum. Could she have Hokum here? I don't. She doesn't drink. Like Hokum could be associated with like a thiamine deficiency, but I can't like B1, like a wet berry maybe, but I can't. She's not like tall. Myocardial infarction doesn't show any ST elevations. Constrictive pericarditis, not sure. So, yeah, okay. It's mitral stenosis.
This patient's clinical presentation, cough, progressive dyspnea, and orthopnea, is consistent with pulmonary edema, with rapid decompensation due to development of new atrial fibrillation, AF with rapid ventricular response RVR. Her history of recurrent sore throat and origin from a country with high incidence of rheumatic heart disease make rheumatic mitral stenosis the most likely diagnosis. Rheumatic mitral stenosis is an insidious progressive disease, and patients can remain asymptomatic for several years. During pregnancy, physiologic increases in heart rate and blood volume raise the transmitral gradient and left atrial pressure at rest and during exercise. As seen in this patient, these changes often precipitate symptoms of fatigue, exercise intolerance, or dyspnea in previously asymptomatic patients with rheumatic mitral stenosis. These patients are also at increased risk of developing AF, the loss of an effective atrial kick, and decrease in diastolic filling time seen with AF and RVR. I pulse 100/min further increases left atrial pressure, with dramatic worsening of pulmonary congestion and pulmonary edema.
Okay, so looks like she has pulmonary edema. She has, the diagnosis is this.
Pulmonary edema with rapid decompensation due to development of new atrial fibrillation AF.
Secondary to.
Rheumatic mitral stenosis.
Interesting.
A 22-year-old man comes to the office due to worsening burning sensations in his hands and feet for the past several months. He also reports soreness in his mouth and has had intermittent episodes of a postprandial bloating sensation and diarrhea. The patient drinks alcohol occasionally, but does not use tobacco or illicit drugs. He is sexually active and does not use condoms consistently. Vital signs are within normal limits. BMI is 20 kgm2. On physical examination, the tongue appears red and smooth. The neck is supple and has no lymphadenopathy. Heart and lung sounds are normal. The abdomen is soft and non-tender. Neurologic examination shows decreased pinprick and vibration sensation in the bilateral fingers and toes. Muscle strength and deep tendon reflexes are normal. Laboratory testing reveals microcytic anemia. Which of the following is the most likely underlying cause of this patient's symptoms?
Smooth red tongue. Reminds me of like Kawasaki and of scarlet fever, but rheumatic fever. But let's see. What causes a neuropathy with microcytic anemia? Oh, microcytic anemia. So that could be like a B6, maybe thalassemia. It could be like a mycoplasma pneumoniae. What's gonna cause neuropathy though? they're installing a cable outside. So I'm probably going to just let it talk at this point and finish up here. Let's just go with no. Maybe. Possibly. Fuck it. Let's go. I was gonna say celiacs. I was like, wait. Diarrhea. But I didn't know it causes some sort of neuropathy. Is it because of the decreased vitamin uptake? Oh, geez. Stock and glove distribution.
This young patient has developed progressive paresthesia and sensory loss in a distal symmetric, stocking glove distribution. This is characteristic of a length-dependent axonal polyneuropathy, which raises concern for an underlying systemic disease. The findings of atrophic glossitis, eye smooth, red tongue with burning pain, microcytic anemia, and gastrointestinal symptoms, egg, bloating, diarrhea are suspicious for celiac disease. Celiac disease is an autoimmune disorder triggered by gluten ingestion. Classically, an immune response to gliadin causes inflammation in the small intestine, resulting in atrophy of the villi, leading to malabsorption. In addition to gastrointestinal symptoms, malabsorption can result in other clinical manifestations, including iron deficiency anemia, and bone mineral disorders related to vitamin D deficiency, egg osteomalacia, osteoporosis rickets. Other extraintestinal manifestations of celiac disease may be related to an overlapping autoimmune response, peripheral neuropathy, seen in up to 50% of patients, and other neuropsychiatric manifestations may be due to autoantibody production rather than nutritional deficiency, because they often precede symptoms of malabsorption. Although atrophic glossitis may be caused by vitamin deficiencies, it might be due to autoantibodies, given that it manifests early in the disease course.
Interesting. Yeah, I saw constant diarrhea, and I was like, oh, if he has constant diarrhea, like, I thought, like, I don't know, the villi was destroyed. What has the villi destroyed? It's not destroyed, but it's atrophied.
A 34-year-old sexually active female comes to your office because of urinary frequency and dysuria for 2 days. She has had 2 such episodes in the past, each treated with oral antibiotics. Physical examination reveals suprapubic tenderness, and her urinalysis is positive for nitrite, leukocyte esterase, many WBC, and a moderate amount of bacteria. Which of the following is the most common reason for the higher incidence of urinary tract infections in females than in males?
Let's move on. What are you, a pre-med?
A 60-year-old man is evaluated for a right lung mass, which was discovered on a chest x-ray performed 1 month ago due to persistent cough. He has had no chest pain, dyspnea, or hemoptysis. The patient has no other medical conditions and takes no medications. He is an ex-smoker with a 20-pack-year history. Physical examination shows clear lungs, normal heart sounds, and no lymphadenopathy or abdominal organomegaly. CT scan shows a 4 cm mass in the right oblique fissure with no enlarged lymph nodes. Bronchoscopy-guided biopsy reveals squamous cell carcinoma. A subsequent PD scan shows no metastatic lesions, and a right pneumonectomy is planned. Which of the following is likely to provide the best assessment of postoperative pulmonary morbidity in this patient?
I just know that with COPD, they assess it off the BODE criteria, which is BMI, ortho, or obstructed FEV1, and then D for dyspnea subjectively, and then E for exercise capacity. And since FEV1 was one of those, I guess that could be one too as well. But this one's just kind of right there. So I just kind of thought that.
Indications for lung resection include malignancy, severe chronic obstructive pulmonary disease, COPD, and persistent infection despite medical treatment. An important consideration prior to lung resection is whether the patient has enough pulmonary reserve to maintain adequate lung function following surgery. FEV1 and diffusion capacity of the lung for carbon monoxide, DLCO, obtained by preoperative pulmonary function testing, are the best predictors of postoperative outcomes following lung resection. Surgery. Based on preoperative FEV1 and DLCO measurements, the percentage of planned lung resection at approximately 50% in unilateral pneumonectomy is used to estimate postoperative FEV1 and DLCO. Patients with an estimated postoperative FEV1 or DLCO of 40% are at elevated risk of postoperative morbidity. Choice A entitled CO2 measurement Capnography is indicative of aerobic metabolism and can be used to monitor correct endotracheal tube placement or to measure the effectiveness of cardiopulmonary resuscitation. Choice C, maximal inspiratory pressure or negative inspiratory force, is a measurement of inspiratory muscle strength. It is often used to monitor patients with hypoventilation due to neuromuscular disease, myasthenia gravis, Guillain-Barré syndrome, and help assess the need for mechanical ventilation. Choice D, measurement of oxygen saturation during exercise, is used to evaluate the need for home supplemental oxygen therapy in patients with COPD. Choice E, the ratio of residual volume to total lung capacity increases in patients with COPD due to air trapping and lung hyperinflation. A high ratio correlates with poor overall outcomes in patients with COPD, but it is not predictive of postoperative outcomes following lung resection. An 80-year-old woman with multiple medical problems is admitted to the hospital for evaluation of syncope. Her heart rate is found to be 36/min. She was admitted to another hospital recently, then discharged to an acute rehabilitation facility, and then sent to a nursing home. Review of her history shows that the patient is taking high-dose diltiazem metoprolol and atenolol. Which of the following medication reconciliation interventions is most likely to result in a decrease in adverse drug events and healthcare utilization?
I'm between these.
Transitions of care between inpatient and outpatient facilities and between units within inpatient facilities are potential sources of medical error. In particular, continuity of care for medications is especially problematic, and errors can lead to an increased risk of medical complications as well as cost. As a result, most inpatient facilities in the United States have instituted protocols to improve the accuracy of the medication record during transitions of care. Objective studies to identify best practices for medication reconciliation have been limited, with few interventions confirmed to improve quality of care. Choices A, B, C, and D. However, interventions that target pharmacy personnel and high-risk patients in particular appear to have the most impact on the quality of patient care. Educational objective: continuity of care for medications at the time of transitions of care between inpatient and outpatient facilities and within inpatient facilities is a potential source of medical error. Interventions that target pharmacy personnel and high-risk patients appear to be the most effective in improving the quality of patient care.
So basically blame the pharmacist.
A 49-year-old man comes to the office for a follow-up appointment. The patient has type 2 diabetes mellitus that was diagnosed 6 months ago. He takes metformin twice daily, but says that it makes him weak and causes abdominal pain and diarrhea. The patient does not engage in regular physical activity, but says he is willing to start an exercise regimen if it will help him with his diabetes. Item 1 of 2. Based on the study results, which of the following is the best response to this patient?
I don't know if you remember the last time we did this. We were like, go straight to the starry stars. There are no starry stars, but there are confidence intervals. Okay, let's see. So like with confidence intervals, they can't include 0. These don't include 0 technically. So It's like, okay, what's T1? Type 1 diabetes? Type 2? No, it's how long. But the results show, yes, like there is an overall improvement. However, that was key right here. They're not consistent across all different types of volumes of exercise, aka length of exercises. Let's keep moving.
Which of the following is the strongest additional support for a causal relationship between exercise and discontinuation of glucose-lowering medication treatment in this randomized controlled exercise-based lifestyle intervention study?
So what is like really good? You can never completely eliminate bias, can you? Is that really additional? I think we see it. Wait. No, there is no difference. Damn, bro. What? I don't even know.
Randomized controlled trials, RCTs, offer the highest level of support for causality because they can establish whether particular exposure, exercise causes an outcome, discontinuation of glucose-lowering medication treatment. In RCTs, a statistically significant association between the exposure and the outcome supports causality, but any significant association is more likely to be causal if its strength, magnitude of relative risk R, increases as the exposure to the risk factor, exercise increases. This phenomenon is known as a dose-response biological gradient relationship. Absence of a dose-response relationship, however, should not be taken as evidence against causality. In this study, patients in the exercise-based lifestyle intervention group were significantly more likely to discontinue glucose-lowering medication at 12-month follow-up compared to patients in the standard care group, p equals 0.003. In addition, results show that patients who engaged in greater volumes of exercise from T1 to T3 were significantly more likely increasing Rs from 12.1 to 25.2 to 38.9 to discontinue treatment than patients in standard care, as shown below.
Why'd they do relative risk though? Shouldn't it be like absolute risk reduction or something like that? I don't know if relative risk is the best way to
An association between a risk factor and an outcome is more likely to be causal if its strength increases as the exposure level increases, i.e., dose-response relationship or biological gradient. Although a dose-response relationship is a highly important factor in favor of causality, it is not necessary to infer causation.
Two more.
A 52-year-old woman comes to the office due to intermittent pain on the right side of the face for 3 weeks. The intense, sharp pain on the right cheek and lips lasts several seconds and recurs several times a day. The patient is afraid to brush her teeth or drink cold water because both trigger the pain. She is pain-free between episodes. She has a history of hypertension, type 2 diabetes mellitus, and seasonal allergies. The patient does not use tobacco, alcohol, or illicit drugs. Temperature is 36.9 C, 98.4 F. Blood pressure is 136/84 mmHg, and pulse is 80/min. No rash or facial asymmetry is noted. The remainder of the neurologic examination shows no abnormalities. Which of the following is the most likely cause of this patient's current condition?
Like maybe like a trigeminal neuralgia, but that's actually just what is trigeminal? Tic de la Roe. What is all that associated with? Maybe. What onsets it is cold water, maybe? I don't know about that. There we go. Got the diagnosis, but
This patient with unilateral, intermittent sharp pain of the right cheek, and lips that last several seconds and is triggered by minor stimuli, brushing teeth, drinking cold water, likely has trigeminal neuralgia TN. Characteristic clinical features of TN include the following: paroxysmal severe attacks of neuropathic pain, shock-like stabbing, lasting a few seconds to 2 minutes, unilateral pain involving primarily the V2 and V3 distributions of the trigeminal nerves, CNV, innocuous triggers, chewing, talking, brushing teeth, anallodynia, pain to light touch, absence of other neurologic deficits on examination. The pathophysiology of TN is thought to be related to compression of the trigeminal nerve root as it enters the pons, leading to demyelination and atrophy of the nerve. Compression most commonly occurs due to a vascular loop, neoplastic growth, or multiple sclerosis plaque. A 26-year-old woman comes to the office due to insomnia and fatigue. She is accompanied by her husband, who is concerned that his wife is exhausted and seems overwhelmed by the responsibilities of being a new mother. The patient had an uncomplicated vaginal delivery and took an extended maternity leave to care for their daughter, who is now 3 months old. The patient feels very tired because she awakens early at 4 a.m. and is unable to return to sleep. She frequently lies awake in bed and worries that she's a bad mother. During the day, she has little energy and forces herself to take showers and care for the baby. Physical examination is unremarkable. The patient appears sad but says, "I'm sure I would feel better if I could just get some rest." Which of the following is the most appropriate next step in management of this patient? Although interrupted sleep is common in new mothers, several features of this patient's presentation are concerning for postpartum depression, including her marked sleep disturbance with early morning awakening, low energy, sadness, and impaired functioning, forcing herself to shower and care for the baby. All patients with symptoms of depression should be assessed for suicidal ideation. Therefore, the most appropriate next step is to assess this patient for suicidal thoughts. Postpartum depression is common and, if left untreated, can result in impaired maternal-infant bonding and negative impact on both maternal and infant health. Patients with severe depression may be suicidal. Assessment for suicidal ideation is therefore critical, as hospitalization may be necessary if the patient is actively suicidal or has thoughts of harming the baby.
all right, there we go.